Thank you, Dr. Abdul Hakim. It's always nice to be back here in Jeddah, and we'll shift gear now to solid organ transplants. And I think bacterial infections are very wide, and I'll just try to take you through them very quickly, taking the chance to know the prevalence and what should we think of. Uh, so let's start. So initially, we know that transplantation is becoming one of the things that we used to nowadays, since it was started decades ago, and now it is increasing. And we also have different type of transplantation other than kidney transplant. It was that was started in 1954. Uh, and with that, we were hoping that we will have a very nice survival for the patient, but unfortunately, of course, with infections, cancers that are becoming the main barriers for disease-free survival after organ transplantation, we started to have new challenges. So a big part of these infections are bacterial infections that is associated with a lot of morbidities and mortalities that we are facing in our patients. Okay. So as an incidence in general, you can see that there is difference between every graft. In kidney transplantation, we don't have as much problems as we have with lung and other type of transplantation, especially also liver transplantation. And among all of these infections, the majority is bacterial infections. Yes, we do see fungals, viral infections, parasitic infections in solid organ transplantation, but still bacterial infection is the main issue here. And it's not only about immunosuppressive therapy. We do have other things that's affecting the patient immunity and making the patient actually high risk for infections. For an example, if we go early where the patient has the procedure, the surgery itself is a risk factor with having wounds, drains, a lot of foreign bodies, central lines, prosthesis that the patient will have. All of these things will affect even immunocompetent patient. And then also the graft that we are going to use to the patient where you might have dysfunction or necrosis that will increase the risk of infection. And then the background of the patient. We don't transplant a young patient. Usually it is relatively elderly patients who does have a chronic disease for a long time and has an dysfunctional immune system, malnutrition status, and also other comorbidities like diabetes, hypertension, a lot of other things that might affect the patient himself. And then we go to after the transplant where we do have sometimes chronic wounds that it's difficult to be healing. And then we might have also invasive procedures, patient on the ICU, on mechanical ventilations, that also will make the patient a higher risk for infections. So it's not only the immunosuppressive therapy, although it is making the major part of reducing infection and causing infections. Now, I know many of you have seen this, where we do think of the pre-transplant and then the early post-transplant, the first month, where you are thinking of the net immunosuppression that it goes down with the induction immunosuppressive therapy that the patient received, and then also to the epidemiological exposure, which is the hospital. So you would expect early the surgical-related infections, and that will be graft-specific. And then you will have nosocomial infections, pneumonia, UTI, and others. And then late post-transplant, we would expect other infections that we usually try to target with prophylaxis. And this is how we should think about it. So we have a donor that he might also have underlying diseases, colonization, especially for deceased donors where they are already in hospital They might be under mechanical ventilation at the time, and they might have a lot of sources that might cause infection. And then we have the recipient who has been a visitor to the hospital frequently and is also carrying a lot of colonization, previous infections, maybe also devices, lines, and others. And then we have the community-acquired infections that we also should think about when we are evaluating our solid organ transplant patient. And then post-transplantation as early as we can see hospital-acquired infections. So the donor screening, and that's why we take the donor extensively and screen them, especially for the living-related donor, where we do have a chance to do an excellent workup in terms of clinical assessment, a lot of investigations, either lab or radiological investigations, and then you will decrease the chance to have a donor-driven infections where you are almost certain that hopefully nothing will happen. But then you still have a problem with the deceased donors where you don't know everything that you want to know. So for the donor-derived infections, we always need to make sure that we had an epidemiological history, extensive microbiological assays, and screen for all common pathogens. And here we are talking mainly of bacterial today. And then if they have an active infections, you need to make sure that these are infections that are treated and there is a minor chance of transmitting this to the recipient. And then perioperative prophylaxis, especially for the MDROs, which we face almost daily with our organ transplantation. We have also we need to know with all of that, we still have a risk of having a donor-derived infection. So even if you did everything, even if you had an extensive workup and also preoperative prophylaxis, you still have a risk factor to have the infection. So these are reported infections from donors, and you can see that we did have reports of almost all bacteria that we know. We talk about gram-positive, gram-negatives, anaerobes, and also other unusual pathogens to see in donors like Forcella, Legionella, Nocardia, were all reported before. So you need to be vigilant when you screen your donor. And this is the organ procurement and transplant network in the US, where they went through their reports to see how much organ has been transplanted and then caused an infection. So the donor-derived diseases were a lot, including bacterial infections that being transmitted through donors. You can see here that they are sure about some, but there are some also potentially related. A lot of the recipient had the same infection from one single donor. And then also you can see that it's different from graft to graft. Okay, so how we should evaluate the donor in case that we do have some risk of infection. So if the donor is bacteremic, and I think people who were there when Dr. Amani was talking this morning, she went very nicely through this, where we need to be very careful in bacteremic patients. At one point, we used to reject all of those, but nowadays we need to make sure that we first treat the donor for at least 48 hours, ensure clinical response, and after that, you can go ahead with the transplant. Of course, it's case by case, but still you need to treat the recipient like they had the infection. Now, if you have this bacterial patient, you need to make sure that there's no metastasis to the organ, especially the organ that you are interested on. And then you need to make sure that you screen your patient even after. So we usually do even culture after transplantation to ensure we have clearance. Now, the issue of the multi-drug resistant that we have here in the country, where we do actually have most of these cases with multi-drug resistant gram-negative bacteria, and you need to have a risk-benefit assessment. Many of these cases, you don't have antibiotic option, and it will be very difficult to transplant those, even if the donor was relatively stabilized. But in case that this multi-drug resistant bacteria has been found in your recipient few days after transplantation, you might not have much of options. So you need to evaluate the risk and benefit. You need to have an alternative plan where you need to have antibiotic option to use for your recipient. Now moving to the nosocomial infection, which is more common in these patients. This is very nice draft from a very large cohort, more than 2,000 patients, where they tried to see the most common sites for bacterial infections. And you can see that there is big difference between the organs. So if we go through the first one, so for heart transplantation, you can see that they do have some urinary tract infection, some bloodstream infections, and then the rest is variety of others. But when you go to the second one with kidney transplantation and kidney pancreas, of course, urinary tract infections is taking over here. And when you go to the third one, you can see that you start having more intra-abdominal infection with liver transplantation. And of course, it's expected to see the respiratory infection with lung transplantation. So it is graft specific. You need to first go to the graft site to investigate the patient who is having fever, because there where the money is, and you need to rule out that infection first before going to any other areas. And then for the prophylaxis during the first month following transplantation, of course, it is variable. And again, today in the morning, I noticed that also different centers use different antibiotics. And nowadays, it should be personalized because you don't have much of antibiotic options, and the needs of every patient is different. You need to assess every patient for their colonization, for the donor colonization, and then if there's any previous infections, and based on that, you can decide about the antibiotic prophylaxis. Here, we are not dealing with a young patient who's coming for a appendectomy and does not have any hospital visit before. So there's a lot to know about the patient before deciding about the prophylaxis option. Now, the surgical site infection, of course, it's a majority of bacterial infection early post-transplantation. It does actually report it to be associated with also affecting the graft. And if we also take it through the graphs one by one, you can see that in kidney transplantation, it's 3 to 11% of the patient will develop surgical site infection. And then beside it, you can see the common bacteria. So here we are talking about gram-positive mainly. Minor increase in the pancreas or kidney pancreas of the percentage, but still we are talking about almost the same bacterial surgical site infection. But we do have a significant increase of surgical site infections with liver transplantation, where we have it up to more than 1/3 of the patient. And then you start seeing more gram-negative causing surgical site infections in liver transplantation. Almost similar with the intestine, where you do have gram-positive and gram-negative, but less with heart and lung. And with lung, again, the reports has showed that the surgical site infection also had reported to have gram-negative and some of the bacteria that we usually see causing pneumonia, and eventually here causing surgical site infection in lung transplantation. So specific antibiotic regimen and duration vary, as we just mentioned, and we need to make sure that we provide the patient with what he really needs, and we need to make sure that we cover all the MDROs that we need to cover for the patient and the recipient to minimize the risk of the infection, and then again make it personalized to the patient. In the same time, providing the antibiotic without appropriate reason will increase financial cost. It's also will not make Dr. Rabab happy because of the C. diff, and then also will increase the rate of the resistance, as you know, and then the adverse events with all of these medications that the patient is receiving. You might have a lot of interactions and a lot of adverse events. Now, talking about the bloodstream infection, this is a Danish group, which is a very large group, more than 1,300 patients, where they studied bloodstream infection post solid organ transplantation. It's quite interesting for me that to see heart transplant actually were the lowest of having bloodstream infection post-transplantation. This is a cumulative incidence, of course, and then you can see the rest of the organ transplantation having around 20% or more of bloodstream infection, where the liver and lung are the highest. It's also very interesting to see that they try to look for the risk factors. So if you have a patient who is above than 55 years old, he's a higher risk to have bloodstream infection than others. The gender was not causing the problem, although the CCI score and also the retransplantation. But if the patient is having CMV infection post-transplant, he's a higher risk to have bloodstream infection. And also, if the neutrophil count less than 1,000, that's another risk factor to have bloodstream infection. So it's quite interesting to see that things that you might think it's related, it's not related to the bloodstream infection, and other things has been correlated for a reason or another with bloodstream infection. In their cohort, the mortality was around 5 to 14% for those who had bloodstream infection after solid organ transplantation. I know that UTI in kidney transplant will need a full lecture, but you all know that this is the area where you will have a lot of infection. You might have recurrent UTIs. You might have an issue with the anastomosis. You will have multi-drug resistant the enterobacteriaceae causing infection in kidney transplantation. And it is one of the issues that you need to deal with early post-transplant, where you need to investigate the patient thoroughly and make sure that there is no graft-related infections. Also, as we mentioned, pneumonia is more common with the lung transplantation, and intra-abdominal infection is more common with liver transplantation. CNS infections post-solid organ transplant, as per the reports, is very common with fungal infection, with viral infection, and less with bacterial infection. So still happen, it's reported, but it's not as common as the others. Now the impact of the multi-drug resistance. So these people are higher risk for infections. The donor and the recipient resistant profile for all prior isolates, as we mentioned. It might be colonized or infected with a lot of pathogens that will need covered with antibiotics that might cause pharmacological interactions, and you need to be vigilant for any of that. The treatment duration should be discussed on individual basis. Most of the clinical trials about shortening antibiotics is not actually including solid organ transplantation. So I would do it, but I think we should do it case by case. Okay, so the take-home message of today, what I tried to say today that it's bacterial infection in solid organ transplant is frequent. It does cause mortality and morbidity. It is graft specific, and it does have happen mainly in the first month with a lot of surgical related infections and hospital acquired infections. The diagnosis should combine the available knowledge of the donor and the recipient. We should establish the immunocompromised status of the patient, And then also we need to know our antibiogram and the nosocomial infection that we are usually facing in our previous patients as well. And then finally, the antimicrobial resistance is one of the issues that we always face and does cause a dilemma at the bedside that we always try to take it as a team consensus and discuss it with the transplant team and also with the infectious diseases team. Thank you.